The final lecture of this session will be by Professor Anthony.
Calcutta, you would all remembered, Shoaib Akhtar was bowling a fantastic reverse swinging Yorker, which cleaned up Rahul Dravid. So the whole stadium was silent. After that, suddenly everybody started clapping. They thought they are clapping for Shoaib Akhtar, but no, it is because Sachin Tendulkar was coming inside. In a sleep conference, worst scenario is talking after Mohan sir, then my buddy Srinivas Kishore, and the ever famous Vijay Krishnan. Only person who was missing from Chennai is Saktesh, who is sitting there, and you are asking me to talk something which is not a very common topic. First thing. Second, I want to thank Shankar and Madhu for doing this Thuyilcon 2. We all know Thuyilcon 1 was a great success. So Thuyilcon 2 is also will be a great success. I am happy to come and share the happiness with them. And this is a place I did my MBBS, DLO, MS. I was assistant professor here. I was a professor and now I am a director there. My alma mater, which is Madras Medical College, the great place to do your post graduation and a great place to spend so much time there. I thank the Almighty for giving me the opportunity. So I am talking about a dry topic which I am supposed to talk for 20 minutes, and I know I am standing between you and your very sumptuous Visharam biryani. So I am going to make it as fast as possible. All these things are all came to my mind because some time back I was operating barbed wire and 2-3 patients. After that I had a patient who is very naive, always complaining this, that and all. I used to discuss with everyone, Saktesh and all the sleep surgeons. He is complaining about this, complaining about that and all these things. I think Ravichandran knows. But what happened, that patient came and told me after the surgery the smell increased for him. I was wondering, then I inquired quietly 2-3 patients after that. Everybody says their sense of smell improved after doing the OSA surgery. So I thought it is because of retropalatal olfaction, or when you swallow there is a fragrant goes, the odorant molecule goes through the postnasal, which was closed all along. Now it is going. Because of that, patient is having regaining back the smell. So this I thought this looks very interesting, and went to my literature. Yesterday we were talking. It's about 12 o'clock in night. I saw so much things about the topic. So I immediately called Shankar and said, this is what I am going to talk. And then only I understand it's such a dry topic, and nobody likes, only few people, few ENT surgeons who don't consider themselves as a surgeons, but they consider themselves as an academicians. They want to do a research. This is the topic for them. All along this we have been talking about surgery. He says pediatric OSA, go do tonsillectomy, everybody is happy, and there is a revision what to do. Vijay says everybody is going there. Next revision I am going to do this. But this, if you are very dry person and you want to do a research, this is the topic. Okay, so in obstructions, maybe a hard obstruction and soft obstructions. Hard obstructions occurs in the nose mainly, and of course it can occur in the maxilla, can occur in the mandible and the hyoid bone level, but the commonest thing is in the nose. So whenever there is a nose, the airway will get blocked. The airway get blocked, the air will not go to the spaces. That's not the only reason. Okay. So second reason is there are in a second reason is there is an inflammation occurs in the body which causes the decreased sense of smell. How this happens? These are all two different things. OSA is an airway problem. Smell is an olfaction is the olfaction is the different sense. But when Mohan sir said, it told about epiglottis, in few animals, the smell comes from the epiglottis. So epiglottis comes up to the soft palate, the smell stays there. Probably because of these inherent long-standing phylogenetically long duration of connection, it still there is certain amount of connection occurs when there is no proper airway, the olfaction comes down. So the higher olfaction dysfunction is seen in OSA, and so to go before that, I want to actually I want to talk much about olfaction, which I know this is not the place to talk, because we are all already running short of time by more than 1 hour. So you know, the smell is the oldest sense. It is for those days we used to say identify the friend, foe and the prey. So this is the commonest thing, and your partner. So it causes a memory and emotional behavior. And clinical importance is, when you don't have the smell, you will have loss of appetite, weight loss, depression, which will make you eat more and earn weight, and gas leak detection and fire detection are all very difficult. So evolution of olfaction is very important for the health. I am not going to go about the surgical anatomy of olfactory epithelium, histology, all this stuff, because you know it is all boring. So retronasal olfaction or retrograde olfaction is something which you got to keep in your mind when you are doing a nasal surgeries, particularly when you want to the best way to go inside, the freakiest way to go inside a sphenoid is you open up the superior meatal window, cut the superior turbinate and identify, and you completely remove. This is okay to do a radical surgery like skull base surgeries, but it is not advisable to do when you are doing a functional endoscopic sinus surgery, because that will cause the main function of superior meatus is get the olfaction from the nasopharynx. So when you swallow, the air goes inside, the patient will smell, that will go off, which we don't recognize. So the aim of this study is to evaluate the increased olfactory acuity following palatal procedures, was the first one, and then patient undergo the palatal surgeries pre-operatively, post-operatively evaluated for the smell. And the reasons to review, there is a gap between the knowledge of OSA and the olfaction. Existing literatures and an impending investigation necessary for the betterment of this interaction to improve the sleep and the human sense of smell. So the postulated causes for decreased smell in OSA is there is an hypoxia. Local hypoxia causes local inflammation, increased cyclooxygenase and deoxygenase. So this will cause local inflammation. This inflammation will cause mucosal and olfactory epithelium inflammation, which will cause decreased or olfactory dysfunction. Then there is a systemic cause. All the patients who have got OSA also has got an inherent generalized high inflammatory state. So this also will cause mucosal edema. Then the OSA and the nose, because as you know, there is a gross septal deviation, high septal deviation, which will cause OSA as well as hyposmia. Then retrograde olfaction and retropalatal obstruction will get reduced. So all these four things postulate together to say the decreased sense of smell in OSA. So there is a 30% of OSA patients will have hypoxia, will compare with only 3%. So there is a definite correlation between that. So what are you going to do about it? There is a negative correlation between the severity of AHI and the hyposmia. Severe the AHI, the hyposmia will be more. The chronic intermittent hypoxia and oxidative stress is the main cause for the nasal mucosal injury and the olfactory mucosal injury. So the treatment of OSA, when you treat the OSA with a CPAP, there is a reduced inflammation, reduced mucosal edema, improves the airway, so more air goes through the olfactory area. The CPAP as well as the surgeries of the nose and the palate increases the sense of smell. So what are we going to do about it? There is a clear correlation between these two, but the cause we don't know literally. So the current gap in our knowledge proposes the direction for future investigation. Anybody who wants to do WHO projects, ICMR projects, want to do some research, you can take up this and look for things like the easier ways to evaluate smell correctly, and do the research on the inflammatory causes, biomarkers, any inflammatory markers which will give you an idea the correlation. The third one is when you do the investigations in future, MRI and PET will give you the functional assessment of the brain as well as the olfactory mucosa in the OSA patients, and how much the improvement occurs. You can without subjective few measurements, you can see objectively, you can see what is the improvement occurs in these patients. And there are genetic factors and recent advances in genomics. You can identify the genes associated with the both, and whether there is any potential overlap, and there is an interaction which is unexplained between these two can be identified. The long term follow up of these studies, comparing the different modalities of the treatment and the effect of olfaction. For example, you use a CPAP for 5 years, what happens to the olfaction? Whether it is keep improving, or after some time it becomes plateau, or it becomes worsen. All these things we can do the studies. And standardizing the protocol for olfaction testing in sleep clinics. So in a sleep clinic, if there's a patient has got a AHI, we check so many things, because it's a metabolic syndrome. We also can have an idea of checking the olfaction. Then you look for biomarkers and all the protocols to do these studies. So the carry-home message is, if you have an OSA patient, there will be a hyposmia. The patient might tell you, might not tell you, particularly in the older people and the females. The hyposmia can occur more, but they may not complain. So growing evidence between these significant connection. Sleep evaluation warrants the patient presenting with an unexplained olfactory distractions, and the olfactory function serves biomarker for sleep. And the patient who comes with the smell disturbance, decreased smell, we always think of one is the post-traumatic or post-viral or other causes for smell disturbance, and you give a steroid trial, all those things. Also give a try whether the patient has got OSA. Patient may not be morbidly obese, still the patient can have OSA, can have a olfactory dysfunction. Then so it's an emerging field of study, serves as a powerful reminder of the interconnection between the nature of human physiology and the importance of the holistic approach to a problem, whether it is a OSA or it's a hyposmia. So this requires further directions needed. So thank you very much. It's only you keep on seeing the surgical plane, but I tell you, if you want to do a research, surgery is not an ideal place to do a research, and these are all the places to do a research. Thank you for your patient listening.
So wonderful topic, sir. We have always seen a spectacular surgical person in you, sir. But Shankar has awakened a sleeping research guy within you.
At the time everyone was sleeping, he has got awakened.
So the research person inside you has come out, sir, in this topic.
So it's my honor to chair your session, sir. You are my mentor, and always I have been constantly following you, sir, in the field of ENT. I'll try to replicate and do something whatever you do. Today you started with saying something about the cricket, sir. I want to appreciate back in the same way, sir. Whoever is going to be the bowler or however the ball has come, you always give a sixer, sir, and that you have done today. Thank you, sir.
I will also add one cricket analogy.
That is the perfect person. You can see in future he will get a Nobel Prize, or minimum he will be he'll get a Batmachri like this thing for this research.
Incidentally, will it improve the omoronasal organ of Jacobson, sir?
Yes, there are two other things which are important. One is the omoronasal organ, and second one is there is a vestigial brain receptors. But actually, what happens is after the advent of vision, the olfactory area is overcoming. You know where is the primitive olfactory area is at the under surface of the brain. The piriform cortex and the entorhinal complex, the tertiary olfactory area are under the brain, while the olfactory area is at the back. When you talk of brain, you touch this area, that is an olfactory area. The optic area, the optic cortex taken over all the other areas, particularly the smell. To an extent auditory area and the smell. We don't need smell these days after the advent of excellent vision. So this got to be investigated, and you can find so many things which are all related in the brain function. You can find out causes for degeneration of the brain, memory, and other age-related disorders by the change of smell.
Thank you, Anthony. You start.
Yes.
Thank you.
Thank you, sir. I would like to felicitate the chairperson, sir.